Accidents happen. It's a fact of life. Are you prepared to be a first responder? To provide emergency first aid until professional help arrives or until you can get the victim to the hospital. This program details everything you need to know to be an effective first responder to individuals suffering from slips and falls, car accidents, cuts and bruises, head trauma, cardiac arrest, or blocked airways. Now you can be prepared. The information you're about to see is being presented by Mr. John Klatt, President and founder of American Safety. Started in 1995, American Safety provides a wide variety of safety training programs for healthcare professionals, businesses, and individuals. Additionally, Mr. Klatt trains United States military personnel in the latest first aid and tactical first responder techniques and has traveled in this capacity to the Middle East on several occasions. Now, it is my honor to present to you Mr. John Klatt with Basic First Aid.
Hi, thanks for joining us. My name is John Klatt and this is Basic First Aid. Every day, tens of thousands of people are injured, even killed, around the home, at work, or at play. And emergency medical services may be minutes, even hours away. The steps that a first responder takes in those first few moments may mean the difference between life and death. In this video today, we're going to show you how to provide first aid for illnesses and accidents. And we're going to give you some first aid tips to help you stay safe if you are a first responder. But first, are you at legal obligation to help someone? Every state has Good Samaritan laws. Good Samaritan laws are laws that protect you in the steps that you take as a first responder. Make sure that you check with your state and local laws before providing care for somebody who you don't know. If you're a member of a workforce rescue team, you may be required to take a blood-borne pathogens course. Blood-borne pathogens is regulated by federal, state, and local laws. Make sure that you check with your employer before becoming a member of one of these teams. Okay, so let's get started. The first thing you need to know about first aid is safety. That is scene safety. Scene safety is there busy traffic, a fire, smoke, gasoline, or other people at the scene? You need to ensure that the scene is safe before you and other rescuers can approach. Once you feel that the scene is safe and there are several victims, you'll need to perform something called triage. Triage means to sort. That is, if there are several victims, you'll need to prioritize each victim and the level of care that they need. If somebody is in cardiac arrest, secondary to trauma, it's very unlikely that you're going to be able to resuscitate them. And spending a lot of time trying to resuscitate one person may not be beneficial in that others may benefit from your care. Another part of scene safety is personal protective equipment. That is gloves and goggles. You may need those to protect yourself against blood and other body fluids. And now to allergic reactions. Allergic reactions are reactions that your body have to snake bites, spider bites, ant bites. It can also be to products like soy products, monosodium glutamate or MSG, or peanut oils. Allergic reactions can stem from trouble breathing, hives can break out, airways can start closing down. So in this scene, we're going to treat Lori here, who's just been bitten by an ant, and she's going to have an allergic reaction. Now, when you approach somebody, you want to make sure that you identify yourself and tell them that you're a first responder and you can provide care. So I'm going to come up and I'm going to say, "Hi, my name is John. What's your name?"
Lori.
It's Lori. Lori, what happened today?
I was working in the yard and I'm highly allergic to fire ants.
And did you get bit?
Yes.
So if she said that she got bit, if you can find out what sort of animal bit her or insect, it's a good idea to go ahead and note that so that you can tell first responders or medical personnel what's going on here. So Lori's been bit and we can see that she's starting to breathe really fast. So an allergic reaction, she could have shortness of breath, her heart rate can be picking up, she may have sweat building up around her brow hair. And then if you notice right here that she's got these red blotches here in her neck and on her chest here. She's having difficulty breathing, and these people that are having allergic reactions may be leaning forward or leaning over something to help them breathe. This is in one case where you don't want to really have somebody laying down because it makes it more difficult for them to breathe. So Lori's having difficulty breathing. We're definitely going to call 911 on this one. I'm going to send somebody to call 911, or I'm going to call 911 myself. And then I'm going to come back and treat Lori here. Now I want to know if she is on any medication. Some people are on what's called epinephrine or an EpiPen or injector should they have allergic reactions. So Lori, are you on any medication for this?
Yes, I'm supposed to carry an EpiPen.
Okay, and where is your EpiPen right now?
It should be somewhere near.
Somewhere around here. So if you can get to that epinephrine pen, you want to grab that right away. And here's the EpiPen right now. This particular pen here injects epinephrine through the leg into the skin here. And the way this works is it's usually in a plastic case. And what you'll do is you'll unscrew the end of the plastic case. It could be yellow or orange. You'll drop the pen out and pull the back piece off. When you pull the back piece off, this will release that injector right there, and I can go ahead and inject this. Now you want to make sure that your state and local laws will allow you to assist Lori in administering this medication. If you're not allowed to administer this medication, she's going to have to help herself. So if you can hand her this pen and have her administer it herself, you should do that. If your law allows you to do this, you may assist your victim in doing this. So the only thing I can do right now is put her in a position of comfort, sitting down so she can breathe like this. We've called 911, and I'm going to take this epinephrine pen, and I'm going to go ahead and inject epinephrine into her leg. When you push it in, it's going to click, and you want to hold that for about 5 to 10 seconds. After 10 seconds, pull the pin out. The needle will still be exposed. You want to put it back in the plastic case and screw the lid on there, and make sure that that stays with Lori so that when she goes to the hospital, they know that she's had this epinephrine administered. Some people will actually need 2 injections of epinephrine. So some of these pins are what's called double injectors, in that you will be able to inject it once, pull it out, and inject again and give the second dose. It'll indicate that on the pin if that's what it is. All we can do now is help Lori breathe. If we have to loosen clothing around her neck, we can do that. Again, we want to make sure that she's away from danger, make sure she's away from the ants here, and that 911 has been called. As I said, other things that can cause allergic reactions are soy products, peanut oils, some bushes, fire ants, as in this case with Lori, and also bee stings as well. Now this medication, epinephrine, is a prescription-only drug. It's not something that you can purchase over the counter. So if you know that somebody has an allergic reaction, you want to make sure that they know that they can get this via a doctor's prescription. If you do not have epinephrine and someone like Lori is having an allergic reaction, an alternative to epinephrine may be Benadryl. We use liquid Benadryl because it absorbs in the body faster. Benadryl works because it's an antihistamine, and typically when people are having allergic reactions to plants or soy products or even latex products, they'll build up histamines, and Benadryl will help that as a histamine blocker. But again, make sure that your state and local laws allow you to provide these medications to the victim. Let's talk about accidents. Robert has just fallen off his bicycle here. Now, if he was in the middle of the street, scene safety is paramount here. You need to make sure that the scene is safe before you approach Robert here laying in the street. So you need to be aware of traffic and other people as well. Now, we don't typically move people that have fallen off their bicycles with possible neck injuries. But in a case where this was a busy street, you would want to move Robert out of the street right away. If you have several people that can help you, that's great. If you don't, you have to move this person because the scene has to be safe. So in this case, we look at something called AVPU. When we walk up to somebody, AVPU, the A stands for are they alert? So if I go up and I see this person and I introduce myself and they talk to me, they're alert. V is, do they have response to voice? Maybe they don't acknowledge me, but when I talk, they can move around. That's voice. P is response to pain, and that is they may be unconscious, but when I rub them in the sternum here or I pinch them up here, that they move when I do that. And then U is unresponsive. If they're unresponsive, we need to do a quick assessment and find out what's going on with them. They may have head injuries, they may have leg injuries. Another priority that we need to do in an accident like this is look for bleeding. We can come up and hold Robert's head, we can go down and look what's going on with all the bruises. But if we see bleeding, we're going to address that right away because somebody can bleed to death pretty quick. So you need to address that as soon as you get on scene. So here, I'm going to approach the scene. I'm going to make sure the scene is safe. And the first thing I want to do is, because he may have been hit by a vehicle, he may have fallen off his bicycle, my main concern is that he might have a head injury or a neck injury. So when I first approach Robert here, I'm going to come up and I'm going to tell him who I am. Hey, Robert, my name is John. I'm a paramedic. I can help you. And I'm going to hold on to his head. If somebody's wearing a helmet, there's no reason to remove it. It may be helping hold his brain here in. So we want to leave the helmet on. If there's bleeding and you have to remove the helmet or you have to do CPR on somebody, then you may need to remove it. But right now, I'm going to hold his head inside this helmet. I'm going to ask him if he can hear me. Can you hear me? Can you hear me, Robert?
Yeah.
Yes. Okay, what happened to you?
I fell off my bike and got run over.
He fell off his bicycle and he's been hit by a vehicle. And asking those questions, they may be basic questions, but they let me know that he's alert and that he's doing well. He's doing pretty good. I'm going to be looking how he's breathing, see if he's breathing fast, if he's sweating. When somebody goes into shock, they're going to be sweating and they're going to be breathing really fast. And so we need to address that, and I'll address that in just a few moments. So I'm going to look down at Robert and see if there's any bleeding. I don't see anything right now, but again, if there was, I would address that immediately. I have somebody else that can help me, and I'm going to have Stephanie hold Robert's head here. Now, I've sent somebody to call 911. If you're alone and you have to call 911, you'll have to leave him. You'll have to tell him to keep his head steady. You don't want them to move their head back and forth because it might make the injury worse. But now I have another person here, another rescuer, that can help hold Robert's head, and then I can start a head-to-toe assessment. 911 has been called. There is no bleeding, and I'm going to ask Robert if he hurts anywhere. This is called the chief complaint. I'm going to go ahead and move this bicycle out of the way here. Robert, do you hurt anywhere?
Yeah.
Where do you hurt?
On this big bruise.
On the big bruise down here. So what I'm going to do is I'm going to go down there and address these bruises. On this leg right here?
Yes.
Okay, so what I'm going to do is look and tell me. You're talking about right here?
Yes.
So what we want to do is we want to address this leg first because that is his chief complaint. Now, when I'm looking at this bruise, it could just be a bruise, which is internal bleeding, or it could actually be a broken leg. The three ways we determine if somebody has a broken leg or a broken arm or hand is mechanism of injury. Now, that is Robert fell off his bicycle and he's been hit by a vehicle, and that could certainly lead to broken bones. Number two is swelling. If Robert has a swelling area right here, and it does look like it's swelling, he could have broke it. And number three is point tenderness, and that is if I touch this. Does that hurt when I touch this? So I'm not going to touch it anymore, but I might immobilize this leg. We might splint his leg using sticks or towels or phone books or any way that we can. We may do that to prevent movement of bones. When somebody has broken a bone in their arm or their leg and it moves around, there are blood vessels inside, and when those bones move, it could very well break those blood vessels and he may bleed internally. As a matter of fact, this bruise right here is an indication that he is bleeding internally. The bruise here is due to bleeding inside his leg, and as the blood leaks out of the blood vessel, it turns dark or black or red like this. So I'm going to go ahead and address this. We may splint this area here, which we're going to show you later. I'm going to ask you, does this leg hurt right here?
No.
Okay, good. Then I'm going to go ahead and straighten out this leg. Let me know if that hurts here, and I'm going to go ahead and straighten that out. Now, I've addressed this. I'm going to make sure that he immobilizes his leg and he doesn't move it. I'm going to address from head to toe, make sure that there's no bleeding. And now I can go back and start at the head and work my way down. Some of the signs we see that somebody has been injured can either be blown pupils or fluid coming out of the nose or ears. This fluid is called cerebral spinal fluid. Now, typically what happens is if somebody has a head injury, the brain swells and it will push this fluid out of the nose or ears. Do not stop this type of bleeding because the brain is swelling, and if you close this off, it's going to put undue pressure on the brain. We can also look at Robert's eyes here. We're going to look at his pupils. If those pupils are equal, if they're the same size, that's a good sign. If one has blown or it's bigger, it could be a sign again of head injury. So we want to be aware of that and note that for the emergency medical service when they get there. So I'm going to look around the head for bleeding. I'm going to look in his nose. I'm going to look in his mouth to see that there's any broken teeth. Any broken teeth in there? Do you hurt anywhere in your mouth?
No.
Nope. I noticed that he has a bruise right here. That's something that's very, very important to indicate here. I'm going to check his shoulders. Now, when you check for broken bones or dislocations, you want to look at the top here. Typically what happens with children when they fall off their bicycle, they'll put their hand out like this. And when they put their hand out, the shoulder will come up, the big bone here called the humerus, and it will move up high, and you'll see a divot in there. So I want to check for dislocated shoulders. I'm going to come down, and I'm going to palpate. Palpate means to touch. When I check Robert for broken bones, what I'm doing is I'm wiggling his arm back and forth, and I'm making sure that his bones are nice and sturdy, and I'm making sure that there's no bleeding. And I'm also taking note as to whether he has any pain or not. Now, when I get down to this arm here, and I get down to his hand, I can do a couple of quick checks here. I can actually take one of his fingers or his thumb, and I can press on that thumb, and the thumb will turn white, the fingernail, and then I can let that go. If blood returns to the fingernail after 2 seconds or less, this is an indication that Robert's got good circulation. That is, he's not going into shock. Typically in shock, the blood will pool to these areas, and this capillary refill will be longer than 2 seconds, 3, 4, or even 5 seconds. So I can certainly see that his fingernails are doing good and that I push the blood out and it returns back in 2 seconds. Robert, do you feel me touching your fingers here?
Yes.
And that's a good indication as well. He can feel me touch his fingers, and that's telling me that he doesn't have any nerve damage in this area here. So now I'm going to go down through the chest here. I'm going to look at his stomach, make sure that there's no bulging or anything like this. If there's any bulging in the stomach, that could be an indication that his muscle tore in his stomach and one of the large organs is trying to press out. I'm going to do the same thing with the other arm. I'm going to come down, I'm going to palpate that arm here, and I'm going to check capillary refill on this hand. And then, do you feel me squeezing your finger? Perfect, he does that. And now I'm going to do the same thing with the leg. Now I'm going to be very careful about the uninjured leg, or the injured leg I should say, in that I don't want to hurt him any worse because that will increase anxiety. So again, I'm going to go down, I'm going to make sure that this leg, just let me know if this hurts here. And then what I can do is I can ask Robert on this uninjured leg here if he can push down on my hand. Go ahead and push down. Perfect. And then I want you to pull up. Now by doing this, by having Robert push his foot down and pull it back, this is also letting me know that he has got no nerve damage, in that his spinal cord, his brain, everything is working well, and he's able to move his toes, move his foot back and forth. And, of course, do you feel this as well, Robert? Do you feel me squeezing your toe? So he feels that. So our best course of action right here is that Stephanie's going to maintain this spinal immobilization on Robert's head. We're going to immobilize this leg because of a possible broken leg. We can't treat any bleeding because Robert's not bleeding, and all we can do now is comfort Robert and wait for the emergency medical team to get here. So when we're back to Robert here, if we think that he broke his leg, the best course of action is just to keep it immobilized until emergency medical services get there. They've got the professional splints, the inflatable splints, that they can immobilize this leg, immobilize Robert to a board, and transport him to emergency services. But if you have time or you're camping and you can't get emergency medical services up to you, you may have to do something. You may have to invent a splint. Certainly it's simple enough to purchase a splint. This is called the SAM splint right here. The concept of this splint here is that it's aluminum with padding around it. And what you can do is you can just fold this over and make it as rigid as you want, and you can run this along the broken bone. Now the idea of splinting is to immobilize the bone so that the bones don't move back and forth and cause any further damage and also pain to your victim. So the concept is that when you splint somebody, you want to immobilize the bone or joint below and the joint above. So if we thought that Robert broke his leg right here, which is the tibia and the fibula, and then this is the femur right here, if we thought he broke a bone here, we want to immobilize his foot all the way up to his hip. And the same thing if he broke this bone right here. So what you would do in this case is you would make this as long as possible. You could put this on the inside and wrap it around his foot. You always want to splint bones and legs and limbs where they lie. So if he had broken his bone, and let's say that it had turned out this way, you don't want to straighten it out. You never want to move that part. You always want to splint it. And if you have to use padding to splint this, then that's what you want to do. So you want to move it as little as possible because there'll be great pain, and also it can cause bleeding. So we can use the SAM splint and put it in this way. Now certainly if you don't have something like this, then you can use something that you can find around the house, whether it be towels or phone books or blankets or even sticks in the backyard that I'm going to show you here in a moment. You could even use the other leg as a splint. If you're going to use the other leg as a splint, you want to pack towels in the center here. You want to put towels here because what's going to happen is if I use this leg to splint this leg, I'm going to move this leg over towards, so you always move the unaffected leg over towards the affected leg. And then the towels will help fill in the gaps here. And then what you want to do is you want to tie these two legs off. Keeping in mind, of course, if you're camping and you need to get out of there and you splint both legs, it's going to be difficult for Robert to walk. So sometimes it's better to use other splinting material. So in this case, I'm going to use a stick that I found out in the backyard. Now, if I see that he's got this injury right here, I always want to place the splinting material on the opposite side because you don't want to put the splinting material on top because obviously that's going to cause a lot of pain for Robert. So I'm going to go ahead and put this stick in the center here. And then what I'm going to do is I'm going to take some wrap material here. I'm going to take some gauze or triangular bandages. I'm going to move this here first. And I'm going to go ahead and set these under his leg. Now notice that I'm taking these triangular bandages or these bandages and I'm sliding it under his knee. There's a natural gap underneath his knee so you don't have to lift up his leg. And what I'm going to do is I'm going to scissor these down into different parts of his leg so that I can use to secure the splinting material. So I'm going to go underneath here. I'm going to go up here. And I'm going to make sure and secure this in at least 3 different places. It's very important to make 2 ties right where that break is as well. So I'm going to take note where this is, and I'm going to go up a little bit higher so I don't go on that break. Now I'm going to go ahead and put my splinting material in there. And then what I'm going to do is when I place this down here is I'm going to make the tie. Now you may want to run this around the leg 2 times. You can actually make two passes around the leg. And then when you tie this off, you want to actually make the tie right on the side of the splinting material. And the reason you want to do that is because if I make this tie up here, it's going to put pressure on his leg. So the tie or the knot should be right on the piece of wood or phone book or blanket or material that you're using. So I'm going to go ahead and make these ties here. And then the second one is going to be here. And again, you may want to loop this around 2 times to make sure that it's going to be secure. So I'm going to make that tie here. Are you doing okay, Robert? Yes. Okay, good. You always want to talk to them. Let them know what you're doing. Don't surprise somebody with something that you're going to do, especially when they're this age. They have a lot of anxiety. They want to know what you're going to do, and really they want to know if it's going to hurt. Now that's something I can't really tell them because I don't know if it's going to hurt, but you want to be careful anyway. So I'm going to make a couple of ties here. Now that I've immobilized this leg here, I should take the pressure off of him moving back and forth and maybe make a little bit of less pain for him and actually a little bit safer as well. Now after you make this splint here, you want to make sure that he still has feeling in his toe. When I did the initial assessment, I found that he could feel me squeezing his toes and his fingers as well, and he had good capillary refill. Down here on this foot here, I want to make sure that he can feel his toe still. And the reason I want to do that is because once I put this splinting material on there, I want to make sure that I didn't do something that's going to cause him not to have feeling in his foot. So once you do something, check it out. Make sure that he's still got feeling and things are still working good for you. We might even take Robert's sock off and check capillary refill. Now, because he broke his leg here, I would expect him to have a delayed capillary refill here, in that the vessels may not be circulating as well through this leg. So we might expect that when we push his toe, if we take his sock off, I'm going to go ahead and pull this sock off here. If we pull this sock off, we might expect him to have a capillary refill of maybe 3 or 4 or 5 seconds. So always check that before and during and after you do procedures like this. Let's talk about heat exhaustion. Now, Lori's an athlete here, and she's been running, and she may have a case of heat exhaustion. The first thing I note is when I come up to Lori is that she's sweating. It looks like she's in athletic attire here, and that she's sitting down and she's having trouble catching her breath. So same thing, I'm going to come up, introduce myself. Hi, my name is John. Can I help you?
Yes, I think I can't catch my breath.
You can't catch your breath. What happened? What were you doing that you can't catch your breath?
I was running.
Okay, so you were running. And do you have any type of medical problems, any medications that you're on or anything like this?
No.
So we're going to establish that this is not something else, and it could be a heart attack or a stroke or some sort of medical condition that she has. We want to make sure that she is just suffering from what's called heat exhaustion here. So the signs and symptoms of heat exhaustion is high level of activity, of course. She might have what's called an altered level of consciousness. That is, she's having difficulty talking to us. I see that she's sweating profusely. She's hot to the touch. In doing vital signs here, we can do a couple of things. We can check pulses. If we check pulses on the hand here, if you want to see what a heart rate is, you can actually go down the thumb here and check the pulse. Now, on the thumb side of the wrist here, if you put 2 fingers into this area here, you should be able to feel how fast the heart rate is going. A normal heart rate on an adult is around 60 beats per minute. So if you were to check your own pulse and you counted for about 30 seconds and your pulse was 30, you could double that and find that your heart rate is normal. In somebody that's suffering from heat exhaustion, we would expect the heart rate to be somewhere around 100 or 120. So if Lori has given me the okay to treat her, I can go ahead and I can look for obvious skin signs here. I see that she's sweating. She has no medical alert bracelet. Always look for medical alert bracelets that could cue you in as to what other sort of medical condition that she might have. But she said she was running. She's sweating. She looks like she's sweating. She's hot to the touch, and I'm going to check her pulse here. And I note that her pulse is about 50 times 50 beats here. I count 50 in 30 seconds, and if I double that, that's going to be 100. So 100, 120 I would expect if she was in heat exhaustion. Another thing that I note is that she's sweating profusely and that she's breathing really fast. Typically people breathe about 12 times per minute, adults, and children breathe about 20 times per minute. So if Lori's trying to catch her breath and she's going and she's breathing really fast, this is another sign that she's either going into shock or she has heat exhaustion. So what I can do for Lori in this heat exhaustion here is we can do a couple of things. We can, one, take her out of the hot environment. It's a hot day, she's been running, she's sweating. So the first thing I'm going to do is have her get up and move to a cooler environment. Number two, I can give her sips of water. We can have her drink water or some other type of fluid replacement. Never alcohol or coffee or anything that has caffeine in it, because that's a diuretic and it's only going to reduce the amount of water inside their body. So water or things like Gatorade is the best treatment here. And so she can drink those. Now if I wanted to cool her down, what I want to do is, if I was going to cool Lori down, we never want to throw water on anybody anymore. Used to be that when we would cool people down, we could throw copious amounts, large amounts of water in their face and all over their chest. And what they found out is when you're using large amounts of water, can actually cool them down too fast and actually slow their heart rate down and can be very dangerous. So with Lori here, what I can do is I can just take a few 4x4s or a rag, and I can just get a rag a little bit wet, and I can cool her down slowly. I can cool her forehead down, I can cool her down around her neck and around her arm as well. And this is a better way of cooling somebody down. Now, should you call 911 here? Typically when people have heat exhaustion, they don't need 911. If you can sit her down in a cool environment and in 10 or 15 minutes she starts to feel better, her heart rate goes back down, her respiratory rate goes back down, and she tells you that she feels better, you may not need to call 911. If she starts to get worse or she doesn't get better in 10 or 15 minutes, then you'll want to make that call. You know, anytime that we find somebody that has heat exhaustion or has been injured or is ill, they usually go into what's called shock. Shock is a very generic term. When your body goes into shock, what happens is that once the body goes into shock because of injury, or in Lori's case, heat exhaustion, the vessels will dilate, the blood vessels. And when the blood vessels dilate, a lot of the blood pools down into bigger areas like the stomach. And so what happens is your heart will start beating faster because it's trying to compensate for the loss of blood up in your brain and in the vital organs. So the first thing that happens that we note is the heart rate picks up speed. That is, it'll be anywhere from 100 to 150 beats per minute. The second thing that happens, because there's more blood that needs to be pumped around, the heart goes faster, it needs more oxygen. So your body responds by increasing your respiratory rate. Now, Lori may be breathing fast because she's been running, but she may also be breathing fast because she's in shock. So the heart rate's going to go fast, she's going to be breathing really fast. And another thing that we can do to help her out in shock is we could actually lay her down. So if we put her in a cool environment and we were to lay her down, and I'll show you this right now, I'm going to go ahead and lay Lori down. I'm going to put her down on the ground like this, and then what I'm going to do is I'm going to raise her feet 10 to 12 to 14 to 16 inches. And by doing that, by raising the legs, it'll allow the blood to pool that's normally down in her stomach to go back into her vital organs where she needs it. And even a hot day like today, we may even cover Lori up, because what happens is, now that we've cooled her down, she may start to shiver because she's going into that shock state. So the heart rate will be fast, the respiratory rate will be fast, and she may even complain about chills. And in that case, we'll cover her up. So here, if we're going to raise her legs here, because we're not worried about any broken legs or anything like this, we can go ahead and take anything that we find around the house or at work, and again, we can raise the legs 12 to 14 to 16 inches. And then this is what's called a space blanket. This is a very lightweight blanket that you can use or have in a first aid kit. You can, of course, use any blanket or towels around the office or at home, but something like this is a little bit more efficient because it's designed to hold the heat in. So I'm going to go ahead and open this up, and I'm going to cover Lori up. And I'll cover her up all the way up to her head here. And then I can kind of tuck this around, and that should store all that heat in. And this is a typical shock position. You can do this for anybody that's been injured, that's you feel is going into shock because of illness. The exception to the rule is when people are having respiratory difficulties. In the later parts here, we're going to talk to you about asthma and things like that, where people are having trouble breathing. You would not lay them down in the shock position. So we talked about heat exhaustion. The next thing, or the worst thing that could happen from a heat-related injury, is what's called heat stroke. Now what happens is when you have heat exhaustion, when you have been exercising or working out, your body's going to sweat, and it sweats so that your skin cools off and it cools your body down. So as we saw with Lori earlier with heat exhaustion, she had a high respiratory rate, her circulatory rate, her pulse was fast, she was sweating profusely, but she was able to talk and drink water. So we put her in a cool place and we didn't need to call 911. But now we're looking at Lori, and it looks like she's not sweating anymore. And in heat stroke, what happens is your body can no longer cool itself down. So typically what we see is, and we have to kind of decide what's going on, we knew that Lori was working out. We see that her clothes are still wet, so she's been exercising and the sweat has still saturated her clothes. But when I look at her face now, I note that it's dry, she's not sweating anymore, and that when I use the back of my wrist here on her forehead, that I note that it's very, very warm. When somebody is red in the face, they're dry and they're warm, these could be signs of heat stroke. Another thing that's going to happen is what's called an altered level of consciousness. Anytime you're working with somebody as a first responder, you want to talk to them, introduce yourself, Ask them questions, what's going on, how they're feeling. In this case, if I say, hey, Lori, how are you doing now? She's not really responding, so she has what's called an altered level of consciousness. So what I can do is the same thing as before. She's still very hot. We still have to cool her down. I'm still going to put her in the shock position, raise the feet. But in this case, I'm going to cool her down, but the most important thing here is we need to call 911. Because when people have heat stroke, they're typically not able to drink any fluids and cool themselves or rehydrate themselves. So you need to call 911 because she's going to need intravenous fluids. So we're going to get her to a cool area, we're going to cool her down, we'll put her in the shock position, but the most important thing we're going to do is call 911. Now let's talk about heart attack. The leading cause of death in this country is heart disease. Every 33 seconds, someone in this country dies from heart disease. It used to be an older, overweight, smoking American that had heart attacks, but we're starting to see heart attacks in younger and younger people here. Chad's having a heart attack. We don't know this yet, but we're going to interview him here in just a few seconds. And then we're going to talk about how to deal with that. Now, in an office or at home, and I noticed that one of my coworkers is having difficulty breathing over here. He's at his desk, he's slumped over. I come in, and Chad already knows me, so I don't have to introduce myself. Hey, Chad, what's going on?
Just a lot of heavy pressure in my chest.
You have pressure in your chest? How long has this been going on?
Maybe 5 or 10 minutes.
5 or 10 minutes. Okay, that's not too bad. Does the pain go anywhere?
It's kind of shooting down my left arm.
It goes down the left arm. When somebody's having a heart attack, they'll typically note that they have pressure in the chest. The pain may be localized there, or it might radiate down the shoulders, sometimes up through the jaw and the back. And in fact, females that are having heart attacks will usually not have pain necessarily located in the chest, but they'll have it in the low back, the upper back, and out through the jaw. And they'll also be very fatigued as well. So what's happening here is, in Chad, his heart is not working as strong as it can. Some of the vessels are possibly being clogged with a cholesterol buildup. And so what we need to do is a couple of things. We may have to put Chad down on the ground and put him into shock position. We may need to elevate his legs. We want to call 911. Calling 911 is very important because they're going to have all the necessary equipment to take care of him, give him oxygen. Also, if Chad's having a heart attack, he may be on medication. Typically people that have what's called angina, that is, they have a buildup of cholesterol in their coronary arteries, and they take a medication called nitroglycerin. Nitroglycerin will dilate the vessels and help them breathe and feel better. So I want to ask Chad if he's on any medication. Are you on any medication for this? Nope, he's not on any medication. It's very important that if somebody is on nitroglycerin or on a medication for their heart, that you do not give Chad their medication. That is a prescription medicine, and it is designed for the person that it is prescribed to. So the only thing we can do is make Chad comfortable and call 911. If Chad tells us not to call 911, recommendation is to call 911 anyway. And then what we're going to do is maybe put Chad down on the floor. I'm going to go ahead and bring him down on the floor. So I'm going to just bring you down, push this chair out of the way here, and I'm going to have you lay down. Now, if Chad doesn't want to lay down, we don't want to cause any more anxiety. If he wants to sit down, sit up against the wall, that's fine. We don't have to raise his legs as long as he's sitting down. We want to get him as close to the floor as possible. Now, if your company has what's called an automated external defibrillator, it's a good idea to get that. In this device, if Chad's heart was to stop, that is, he'd go into cardiac arrest, we would need to, 1, start CPR, which is cardiopulmonary resuscitation, where we would do chest compressions and ventilations. And number 2, we would need to shock Chad early on. That is, apply this automated external defibrillator, where we would open it up, turn it on, apply the pads to Chad's chest. This will actually analyze his heart for us and let us know if he needs a defibrillation shock. But in this case, we're just going to get it for the standby here. We're going to stand by Chad here. We're going to call 911 and send somebody out to meet with emergency medical personnel. We're going to keep monitoring Chad, and if he gets worse, then we're going to provide that level of care that he needs. Now let's talk about fainting and seizures. Some people faint because they may be down low and they get up and the blood pressure drops and they get a little bit lightheaded and go down to the ground. If you see somebody faint, it's not necessarily a medical emergency. You want to go over there, ask them what happened, and provide level of care. Just kind of tell them what's going on, ask them what happened, and if they have to, lay down until the blood circulation returns. And then as long as it doesn't happen again, it's not typically a medical emergency. But somebody that faints over and over again, especially 10, 15 minutes apart, that's something that you may want to call 911 or seek medical attention. Another problem is seizures, though. Seizures can happen from a whole variety of things. Epilepsy, of course, is the most common thing. But seizures also can arise from people that are hot, allergic reactions. They might be drinking too much coffee. So seizures is kind of a generic term in that the ABCs of the human body says a seizure is like a storm of electrical activity in the brain, and that the person might shake or convulse a little bit. They might go down to the ground and pass out momentarily. The most important thing that you can do in a seizure is recognize that a person is having a seizure and move things out of their way. Typically, people don't get injured from seizures unless they hit something on their way down or as they're going through their seizure. So their body may be convulsing or moving or wiggling as fast as you've ever seen, and you just want to keep things out of their way. Now, if you know how somebody's having a seizure and it's not really bad where they're moving their arms around, you might be able to hold their head, try to cup their head to make sure that they're not going to get injured in this seizure. Now, typically, state requirements or state laws say that if somebody has seizures, they have a medical alert bracelet, they're a known seizure patient, and they have these seizures, it's not a big deal. You don't need to call 911. We typically look at, we will call 911 if somebody's never had a seizure before, it's their first one, or if the seizure lasts longer than 5 minutes. So if somebody's having a seizure and it's 4 minutes and 30 seconds, you want to think about calling 911 because it's a long time. Because during that seizure, because they're moving around so fast, they're not really breathing that well, and so you want to make sure that 911 calls because they might need that extra level of care to help them with their respiratory problems after the seizure. So, in talking with Chad here, and Chad and I are just talking back and forth, sometimes a person that has seizures, and we know that Chad has seizures all the time, he may have a premonition that something's happening. Sometimes they even give off a metallic smell. Sometimes we even see animals with seizure patients where a dog might be here and recognize that Chad is giving off this metallic smell and bark to alert us what's going on. So as Chad and I are talking, he starts to have this premonition here, and so I can say to Chad, it looks like he's starting to get ill here, and I'll say, what's going on, Chad?
I think I might have a seizure.
Okay, I'm going to help him down to the ground right away, so I'm going to move things out of the way here, and so Chad is starting to move around, and so as I can see, he's moving around, and I'm going to go ahead and support his head. Now this may not go on too long. This could be 10 or 15 seconds, or like I said, even 5 minutes. As he starts to relax here, he's coming out of his seizure. So it looks like his seizure is almost over here. And so it didn't last more than 5 minutes. We don't really need to call 911. But what I am going to do is support his respiratory need here. Because he's laying on his back, it might be difficult for him to breathe in that his muscles are now in a very relaxed state, also known as the post-ictal state. So in this post-ictal state here, I want to roll Chad onto his side or the recovery position. He's not injured himself in this seizure here, so I don't need to administer first aid there. But what I am going to do is move him onto his side. In rolling somebody on their side to help them breathe, the first thing you want to do is take the inside leg here and move it up nice and high like this. And then what I'm going to do is I'm going to move this arm above his head. I'm going to take this arm over, and I'm going to cup this around his head. And then what I'm going to do in rolling Chad on his side here, and it doesn't matter which side you roll him on, I'm going to grab his leg and his arm, and I'm going to pull him over onto his side. That leg will come down and support him. And in this case, I can support him. I can watch and see how he's breathing, and I'm right here, and I can tell if he's breathing or if he's having difficulty breathing. And then eventually, Chad should recover. As he recovers, the only thing he'll need is rest. People have taken up to 3 days of rest after major seizures, seizures that go on for several minutes. Another thing that we note with seizures as well is something called incontinence. That is, when somebody has a seizure, we may see bowel movements or pee, and people may pee or poop their pants. It's called the fight or flight scenario. And so in that case, it can be embarrassing for some people in a public area. So if you're in a public area and you're providing first aid care for somebody that's had a seizure, take care to note that and help that person out with other people that might be there watching. Sometimes crowd control can go a long way in taking care of your patient. Now let's talk about diabetic emergencies. Diabetes is one of the fastest growing diseases in this country. Sometimes people produce insulin, but the insulin doesn't work well in their body. It doesn't break down the sugar. And sometimes people don't produce enough, and then sometimes they produce too much. In diabetic emergencies, there's kind of a balance between insulin and blood sugar, where some people have blood sugar that's too high or too low. In recognizing diabetic emergencies, we can look for medical alert bracelets, and of course, if you're a diabetic, you want to let people know around you that you have diabetes. Sometimes people will actually have what's called insulin. This is medication that they'll inject. Again, you need to check with your local and state laws if you're going to help somebody administer this medication here. So typically what happens is people that are hypoglycemic or their blood sugar is low, they'll be very lethargic, they'll be weak, they can have a bad attitude. They can actually say things that they ordinarily would not say. They can get kind of mean and nasty, and that can be somebody that has low blood sugar level. And in this case, it's simple enough that we can just give them sugar. Now, when you're giving sugar to a diabetic that is hypoglycemic or has low blood sugar, it is important to give just plain sugar. That is orange juice or mixed sugar, or there's even a medication called glucagon that you can get and give to people, or they might have that on their person. Okay? People that are hyperglycemic, that have high blood sugar levels, will typically have a very fruity smelling breath. They'll be very thirsty. They won't be able to quench their thirst. These are typically people that have eaten a large meal. They've come back from lunch and they've got all these conditions, and they haven't taken their insulin, or their body again is not using the insulin that it's produced here. So Chad's just come back from lunch here, and so I see that he's in this chair here, and he's kind of got an altered level of consciousness. He's chugging this water down here, and I'm going to go up and interview him and say, "Hey Chad, what's going on, buddy?"
I'm really thirsty and I can't get enough water. I just keep drinking water.
He keeps drinking a lot of water. Are you a diabetic, Chad?
Yeah.
I knew it. Okay, so and are you on any medication?
Yes.
Okay, he is. And what kind of medication are you on?
Insulin?
Insulin. All right, so in this case, if Chad is on insulin and if he is not so weak that he can take his own insulin, I'll go ahead and get that medication for him. So I can give him that medication, I can help him to the point where he can administer it himself. Again, you want to make sure that you have the ability to administer it in the know-how should Chad need that medication. If you're ever in doubt, you'll want to call 911 and they'll be able to help you out with this. So in this case, Chad is drinking a lot of water. Now, even if people are hyperglycemic, that is, the blood sugar is too low, typical local laws and regulations state to still give somebody sugar. Even though the blood sugar is still high, we give sugar because some people can't make the determination between hyperglycemic and hypoglycemic, or high blood sugar and low blood sugar. So the typical first aid treatment for a diabetic, whether they're thirsty, have an altered level of consciousness, or very weak and are saying things that they wouldn't normally say, is that we treat them with sugar. We'll call 911, we'll take orange juice, add a packet of sugar to it, mix it up, a high sugar drink, and then allow them to drink that as long as they can. Make sure that the level of consciousness allows them to drink that. And in that case, you've taken care of them should their blood sugar be low. If it's too high, higher is not going to make the situation worse. Now let's talk about hypothermia. A lot of people feel that when they're in areas where there's a lot of sun and it's very warm, that hypothermia is not likely. But in fact, hypothermia is very common in areas like California or Florida where it's typically warm. And that's because people don't typically will dress up, they won't dress warm when they go out into the environment. And water is also another thing that a lot of people will be swimming in water or diving, and they can become hypothermic very easily. Your typical temperature, your body temperature, is 98.6. It only takes a 3-degree drop in temperature for you to become hypothermic. So Chad here has been hiking out in the mountains here, and we've come across him, and we notice that he's shivering. Now, the first stage when somebody's starting to go into a hypothermic state here is they're going to be shivering. That is, the muscles are rubbing back and forth together and try to warm you. So that's what we're going to see. Once somebody goes into a true hypothermic state, they will stop shaking, they will stop thinking or concentrating. They'll have what's called an altered level of consciousness, and then they can pass out and die. So this is a true life-threatening emergency. So when we come up to somebody and we ask them, what happened here? What have you been doing? He's very, very cold. So he's been out, he's been hiking in the mountains. It's a pretty cool day here. So the best thing I can do is re-warm Chad here, whether we do it with warm fluids, water bottles, or anything. So the first aid I'm going to do is warm him up. And I'm going to put as many blankets around him as possible. Sometimes you can get what's called hot packs. There's cold packs and hot packs. These are chemical packs that all you have to do is break them and they'll get hot. And we'll show you those in a few moments. But in treating Chad for hypothermia, if he's shaking and I'm able to warm him up, I may not need to call 911. I can put him in the shock position and elevate his feet. But if he's more comfortable sitting up, that's what I'm going to do. I'm going to give him warm fluids. I'm going to warm him up as soon as possible. Now, if Chad has passed that stage of shaking and he's not shaking anymore and he has a very blank look on his face, as you can see that his face is white and he's not really moving, then this is a true life-threatening emergency. In this case, I'm going to warm him, but I'm also going to put him in the shock position where we're going to lay him down like this. We're going to, again, elevate the feet anywhere from 10 to 16 inches. We're going to cover him up as much as possible, make him as warm as possible, and support his breathing, making sure that he's breathing. The most important thing that we do here is contact 911. Now, in some cases where some people are hypothermic and they've been out in the cold, they can actually get what's called frostbite. In frostbite, what happens is the vessels or the blood inside the body starts to freeze. And when it starts to freeze, circulation diminishes. We typically see this at points like the fingers, the toes, and the nose. And what happens in exaggerated cases is that the circulation is so poor in the fingers because the blood vessels crystallize that there's no blood getting there, and you'll actually see fingers and toes and noses and ears actually turn black. That's kind of a stage of gangrene. In this case, we may not re-warm this person. If you're out in a very cold environment and you note that somebody has hypothermia, you want to warm them up. But if you see frostbite on the fingers and the toes, and you're not out of danger yet, you may not want to rewarm this, in that if you rewarm these affected areas and you warm them up and the blood starts circulating again and you have to go back out into the cold, they're going to refreeze and make the situation worse. So if Chad and I need to get off this mountain and I note that his fingers are dark or blue or black on the ends there, maybe his toes, maybe his nose, and we're still on this mountain, I'm not going to rewarm him, in that I'm going to assist him as best as possible in getting him off the mountain or out of harm's way. If I know that he's going to be in an environment he's going to be able to stay warm, then I'll start the rewarming process. When you're rewarming somebody that has hypothermia or frostbite, again, you want to use towels, you want to use blankets, and you can use hot packs. In the case where somebody has true hypothermia, they may not be able to have any drinks, in that their level of consciousness is so low that if they were attempting to drink hot fluids, they might just spill it on themselves. So you'll have to do the warming process for them, and again, call 911. Let's talk about burns. There are different types of burns, typically first, second, third, or partial thickness and full thickness burns. Now, burns can come from, say, sunburn or people that get boiling water spilt on them, or even chemical burns. And the way you treat them can be different. Typical first-degree burns or sunburns can be treated with cooling water, aloe vera, and solar cane. A second-degree burn can happen from a first-degree burn, and that is you'll start to see blistering on the area. It is important that if you find that there's blisters due to a burn, whether it be from hot water or from a sunburn, that you don't pop the blisters. In treating burns, you want to cover them up. The burn is actually damaging the skin. The skin is the largest organ of the body, and the purpose of the skin is to protect the body from bacteria from the outside. So anytime you have a burn, you're damaging that layer of protection. And so it is important to note that if somebody has a second degree or even third degree burn, that you treat them by covering it up and maybe seeking medical attention here. So we're talking to Chad here today, and Chad's been burned. He's working in a lab today, and he's got a chemical that's spilt on him. In treating chemical burns, there's two ways. There's two general ways to treat this. First of all, if we need guidance on how to take care of this burn, we can use a document called MSDS, which is Material Safety Data Sheet. In a workplace environment, MSDSs are a document that tells you how to treat or provide first aid and the level of care for every chemical that you have in your workplace. So you can certainly always consult that. Second, and generically, if Chad has been burned by, let's say, a liquid, we can always use water to rinse off that liquid. But if he has a dry chemical on his leg or his arm, you never want to use water to clear that off. Because if Chad has a dry chemical on his leg or on his arm or his shirt or his face, and we use water to rinse that off, the water is going to liquefy that chemical and cause an absorption hazard. So the way you treat dry chemical burns is that you want to brush them off with a rag or a brush. And once you get it all off, then you may be able to rinse it. It's not uncommon to rinse something, a burn like this, for 20 to 30 minutes. The important point is you don't want to use water that's too cold. And using too much cold water on a burned area, you can actually cool this person down and actually put them into a hypothermic state. So in this case, where Chad's got this burn here from this chemical, we've rinsed off the chemical here, we've consulted the MSDS, and it's told us to go ahead and wrap this up and then keep an eye on it. We see that it's probably just a first-degree burn in that there are no blisters. So in a first-degree burn, it's just going to be a redness and tenderness of the skin there. In a second degree, we would start to see blistering around the area, and again, you don't want to pop those blisters. In a third-degree burn, typically from an electrical burn, say somebody was electrocuted, we'll see that it is black and charred in that area. In that case, you also want to wrap it up and definitely call 911. So in this case with Chad here, I've cooled down that burn with some water. I've taken some cool rags and I've cooled this down, and I've even put a little cool water on there. But when I go to wrap this up, I don't need any types of ointments or oils or anything to help this burn here. All I need to do is provide another layer of protection for the skin. So anytime you're wrapping up a scrape or an abrasion or a burn, all you really need to do is cover it up with a clean cloth or gauze pad and then wrap that up and then watch that and make sure that it doesn't blister. So what I'm going to do is I'm going to lay some gauze pad over his burn here, and I'm going to take some roller gauze, and I'm going to start at the end of his arm here, thank you, and I'm going to roll this around. Now anytime that you're wrapping somebody up, whether they have a burn or cut, when you wrap them with roller gauze, you want to overlap it about 50% of the existing bandage. That is, as I'm rolling this bandage up and down, I'm going to cover the existing bandage 50% of the way. Some bandages actually have dotted lines that go down the center and assist you in doing that. Now when you wrap this up, you don't need to make it tight. Take note that I'm only rolling this on his arm and that I'm not taking it and wrapping it tight. Because if you grab this roller gauze and wrap it really tight, you can actually cut circulation off to his hand here. So I'm going to make one pass up and then back down. Now when I get to the bottom of this, and I've got all this leftover bandages, sometimes roller gauze will come with tape and pins and stuff like that, and you'll cut it and you'll pin it. You really don't need to use all of that in that. All you need to really do is take a couple of fingers, make a little bit of a gap, swing this roller gauze around, and then you can tuck it in there. And then in doing so, if we ever need to put more gauze on here, we can actually add some more, pull this back out, and use the leftover bandages. It doesn't have to look good, it just needs to protect the skin. And then of course, because I've wrapped this up, I want to make sure it's not too tight. We can actually do what's called capillary refill, like we did with Robert, and we can push in on the fingernails and see that blood is returning to his fingers within 2 seconds. That's a good capillary refill. Thank you. Go ahead and lay this down. Now, in a third-degree burn where there is an electrical burn, typically what happens is if somebody is electrocuted, they'll have a third-degree burn, which is a black charred area. In first and second-degree burns, there could be a lot of pain associated with this. In a third-degree burn, because it's a very deep level, the epidermis has been damaged, and there's actually the nerve endings have been damaged as well. So people may not have any pain with a third-degree burn, but they're very life-threatening in that they may have a burn on their hand, and if it's an electrical burn, electricity must also follow a path. That is, if somebody's been burned, has a third-degree burn with an electrical burn, they'll have not only an entrance wound, but they'll have an exit wound. If they're on a ladder working on an electrical system, the burn could be on their hip, or it could actually be on the bottom of their foot. So it is important that when you're treating, say, a third-degree burn, an electrical burn, you call 911 because organs could have been damaged as that electricity went through their body. You want to make sure and cover up that burn with a dry gauze, and then look for an exit wound. And very important, support the person for other possible organ damage. That is, their heart could have stopped or other problems could have happened internally. Now let's talk about respiratory emergencies. In respiratory emergencies, we had one that was called anaphylactic shock, and that was when the body was having an allergic reaction. Other respiratory emergencies can include asthma, chronic obstructive pulmonary disease, and lung ailments like that. When we're trying to diagnose somebody with a respiratory emergency, sometimes as much information as we can get will help us decide if the person is having anaphylactic shock or they're having a respiratory emergency. Now sometimes people will have what's a blocked airway or a foreign body airway obstruction. Typically when somebody has a foreign body airway obstruction or a blocked airway, they'll have difficulty breathing in. They'll have problems when they breathe in, and we can ask them if they have a blocked airway. And in that case, we do something called the Heimlich maneuver, and that is when we go behind them and do those abdominal thrusts, and we should be able to launch that airway. In other emergencies where we don't think it's anaphylactic, let's say asthma for example, people will be wheezing, not when they breathe in, but when they breathe out. So talking to the person is very important. Now, a general way of treating respiratory emergencies is to find out what this person needs, whether they need their medication or you need to call 911. Now, typically when we're treating people for first aid situations, we'll have them lay down on the ground. This is one time where you do not want to lay people down in the rescue or recovery position or even in the shock position. In that, when people are having respiratory emergencies, they're having difficulty breathing, they'll typically be leaning over a table like this, they'll have their arms spread like this, and they won't want to get down to the ground here. So let's talk to Genesee here. And so first thing I note is that Genesee is in this respiratory distress. And we see that she's kind of grabbing her upper airway here. And so I'm going to, of course, identify myself. Hi, Genesee. She already knows me. What's going on, Genesee?
I can't breathe.
Do you have asthma?
Yes.
Okay. So are you on an inhaler or anything?
Yes.
Okay. Do you have your inhaler with you?
Yes.
Okay, I'm going to go ahead and get Genesee's inhaler here. And again, will I be able to administer it? I may not be able to help her out, but I may be able to hand her this inhaler and help her out with this. So there's not a lot I can do in helping her with her inhaler. She doesn't want to lay down. She wants to stay up so that she can breathe. All I can do is get her inhaler and maybe call 911. She may need oxygen. So what I'm going to do here, give her inhaler, have her take some puffs of that inhaler, and then call 911 and stay with her. And if at any time she passes out or goes unconscious, I'll support her, bring her down to the ground, and I'll start my CPR steps or my ABCs. Another type of respiratory emergency that we might see is where people are actually coughing up blood, and this can be a respiratory emergency as well. Sometimes when people bleed inside their lungs there, they'll cough up blood and it'll be frothy. In some illnesses, like chronic obstructive pulmonary disease, the lung tissue will bleed and blood will come out through the mouth. They'll actually cough that out or gag that out, and it can be frothy. That is, it looks like blood has been mixed with a lot of oxygen bubbles. In this case, this is truly a life-threatening condition. Same thing exists. We don't want to bring that person down on the ground because it's not going to help them breathe, but we want to make sure that they don't pass out. So we always want to provide support and call 911. Let's talk about poisoning. Poisoning is different. Sometimes people may eat something and have a reaction to it, have anaphylactic shock, or sometimes it can, like food poisoning, can give them an upset stomach. They may be vomiting, they may be going into shock. There's two ways of treating poisoning. Typically there's a drug called serpivipacac. Now, if state and local laws allow you to use serpivipacac, what this medication does is if somebody has, say, ingested pills, and we want to get those pills out of their system right away, we would give them serpivipacac. Now, this causes extreme vomiting and diarrhea. So a lot of state and local laws have stopped us from using serpivipacac. Some places you can still purchase this. The reason they don't want us to use this so much anymore is because when somebody has ingested pills and we want to make sure that they throw them up, is all that vomiting and diarrhea causes a lot of anxiety to the victim. So they typically don't recommend it. Another thing that we use in poisoning is something called activated charcoal. Activated charcoal will actually mix with whatever poisoning they have and actually slow the absorption process. Activated charcoal is still used in a lot of local areas. So in treating somebody for poisoning, you have to kind of figure out what's going on. And of course, if you're ever in doubt, call 911, which you may do anyway, or call your local poison control department. And so Genesee here has ingested some poisoning. We don't know what it is at this point. If she was young, if she was a child, then we could ask the caregivers around her what's been going on. If the child has gotten into anything underneath the sink, we want to look around for open containers. We want to see what's in the area, and that will give us some clues as to what's possibly going on. So typically what we see with poisoning is Genesee's holding her stomach here, and so let me interview her and ask her what's going on. So what happened, Genesee?
I ate something and I'm not sure what, but I have really, really bad stomach cramps.
Okay, so she has very bad stomach cramps, and then so she might also be going into shock as well. So if Genesee's going into shock because of food poisoning, something that she's ingested, she might have stomach cramps, she may have vomiting, she might even have some mild seizures there. And so in this case, we may want to put her in the shock position, elevate the feet, and cover her up because she might get the shakes as well. We'll also note that she might have a fast heart rate and her respiratory rate in that she's breathing really fast. So kind of the same thing that we did earlier, in that we can go ahead and check a pulse here. So I'm going to take her wrist and I'm going to check her pulse, and that is on the thumb side. And again, I'll check this for 30 seconds and then I'll double it. And so if her pulse is, let's say, 30, and I double that, which is 60, that's a normal heart rate for an adult. But with somebody that's going through food poisoning, we would expect that rate to be somewhere around 100 to 120, all the way up to 150 beats per minute. I see that she's breathing very fast as well, so she's in a little bit of a respiratory distress. And the same thing, I can take the back of my wrist here and I can actually check and see if she's sweating or she's cool to the touch or she's hot to the touch. And typically they'll be cool to the touch because they're sweating as well. So our key here is how sick is she? Should we call 911? If she doesn't look like she's getting better within 5 or 10 minutes, we may want to seek medical help if it's just something she ate. If I know for a fact that she's overdosed on some sort of medication or some sort of product that is very strong, then I might seek medical attention right away. Now, the other two clues that we can use if we suspect that she's ingested poisoning is we can detect the odor. In that if somebody has, say, ingested some gasoline or something that gives off that type of petroleum smell, you'll be able to smell it on their breath. So say I was working with a child that maybe drank something that was out in the garage, I might be able to detect that odor on their breath. Another thing that we see is things that are caustic or acidic, things that are corrosive. They're going to cause burns. So in looking at Genesee and providing first aid, I can look at her lips and look at her tongue. In that in cases where people have taken things that are going to burn, they might have white burns around the lips there. They'll be kind of crusty. The tongue will be swollen, and it'll look like it's burnt as well. The general rule is that if somebody has taken something that's going to burn on the way down, you would never give them anything that's going to cause them to vomit, because if it burned on the way down, it'll burn on the way up. So in this case, we don't know what she's taken. We can try to find out where she's eaten and contact that, of course, organization. We're going to seek medical attention. If I can take any pills that she may be taking, any kind of medication, I'm going to take them or give them to the medical personnel when we seek medical attention. Eye injuries can be pretty complicated in that you may get something stuck in your eye, or you might get some sort of liquid in your eye. Now typically in a work environment, they'll have water bottles or what's called eye wash stations. If somebody gets a liquid in their eye, again, you can consult what's called the MSDS, the Material Safety Data Sheet, and that might give you some first aid direction on how to treat that particular product that's in your eye. The general rule is if you get something splashed up in your eye, that you'll want to rinse that eye for 20 to 30 minutes. And in rinsing the eye, you'll actually put the person in the sink or a hose or whatever. And if it's, say, the right eye, what you would do is you would direct the water over the bridge of the nose and rinse out that eye, again for 20 to 30 minutes. You never want to put the head the other way and rinse that eye, because the infected part or the product that's in that eye can run into the good eye or the unaffected eye. The other side to eye injuries is that if the eye is actually out of the socket there. If it's out of the socket, you can actually take some gauze and actually kind of hold it up in there, or have the person hold it themselves, or wrap that area up there so it doesn't hang out any lower. As long as it's hanging on to that optic nerve there, and it's hanging on the side of the eye there, the side of the cheek, you can actually put a little bandage around there, make sure that you don't squeeze the eye, and that will support the eye so it doesn't hang on that optic nerve. If you ever incur somebody that has an eye injury and there's something impaled in their eye, you never want to remove it. The general rule is if somebody has something impaled in any part of their body, you never pull it out. But there are exceptions to that rule, and I'll talk about those later. So Genesee has injured her eye here, and I'm going to go up and I'm going to try to find out what happened. And so what happened to your eye? What happened here?
I heard it.
She heard it. So she heard it, and she may have even splashed something in there, or she injured it in that she hit it here. And so I'm going to pull her hand away from here, and it looks like she's got some black and blue around her eye here, and it looks like it's swelling a little bit. So what we can do is that we can go and see an optometrist. We can even take her to an emergency room if we think the case needs be. What I could do for her is I could do one of two things. I can wrap up the eye, or if there's, in the case of somebody has something stuck that's in the eye, say there was a stick protruding, we can actually take this cup and place it over that eye so that nobody is going to hit that stick that's sticking out of her eye, and then we would secure that to the head with bandages. So in this case, I'm just going to go ahead and put some gauze pad over her eye. Now you can actually purchase eye pads specifically for this, and they're little donut-shaped pads that you can place over the eye, and sometimes they'll have what's called dog legs or bandages already attached to them that you can tie it around. But in this case, we don't have that, so we're just going to use stuff that we find around the office. Okay, go ahead and move your hand. So I'm going to go ahead and cover this eye up for her, and then I'm going to wrap this roller gauze. Now when you're wrapping head injuries, they're a little bit harder to wrap around, in that the head is not going to make the easiest environment to wrap. Now in some cases you may or may not cover both eyes. some people believe, that you should actually cover both eyes. You should cover both eyes, and in that way the two eyes will not be moving together, and you can do that certainly. Again, with the roller gauze, you only really need to make 2 passes and cover up that eye. So in this case, we've kind of left that one eye so she can see out of there, but I've covered the affected eye. Now we can seek medical attention and find out what's going on. Let's talk about fractures and bleeding and other types of accidents like that. In these cases where you think there's going to be blood and other body fluids, it's always recommended to wear gloves. In the case that you don't have any gloves and you get any blood on your hands, you want to make sure and rinse them off. We're very concerned that when we get blood on our hands and we have cuts, and that we might introduce toxins and poisons to our body and bacteria from somebody else's blood. So if in any case you can use gloves and barrier devices between you and the victim, or goggles, it's always recommended to do that. Make sure that you follow the protocols that you have in your local first aid guidelines. So Genesee has fallen. It looks like she's fallen down, and I'm going to come up and again introduce myself. She knows who I am, and so I kind of want to find out what happened and give me an idea of what her chief complaint is. What happened, Genesee?
I fell off this ladder and my arm really hurts.
Okay, so I see that she's bleeding right there. Now, in providing first aid, whether she's got any breaks or she's in shock or bruises or anything like this, my first concern has got to be towards this bleeding area right here. Now, in a case where she's possibly broken her arm, she may not want to move it. But what I can do is, if she's bleeding, and there's different types of bleeding, she can actually use what's called direct pressure and elevation. Those are the first 2 steps in controlling bleeding. So if somebody's bleeding, you'll want to instruct them to put their hand over the injury and then raise the arm above the heart, and that may control bleeding. That's most types of bleeding. That is for scrapes and things called venous bleeding. Venous bleeding is where a vein has been ruptured and there's dark blood coming out. Now, in the case of arterial bleeding means that when Genesee fell, she cut an artery that's close to the surface here. In this case, it looks like she may have cut what's called her radial artery. So this artery has got high pressured blood in it, and what happens is, if Genesee fell and cut that, we're going to see blood actually squirting out of the arm. This is harder to control in that there's high pressure, and it's not going to stop if we just put direct pressure and elevation. So in this case, she'll do direct pressure and elevation, and we may have to do something a little bit more aggressive, and that is pinch off the major vessel. So let's treat this bleeding first, and then I'll worry about her arm. In controlling bleeding, I see that she's bleeding here, and so what I want her to do is actually hold on to this injury and elevate it above her shoulder if she can. And again, she may have broken her arm, and that may not be logical to do that. As she's holding on there, I might be able to get some gauze and actually wrap this up and control bleeding. So the first thing I want to do is get some gauze here. They call these 4x4s because they're 4 inches by 4 inches. Okay, I've got it, Genesee. And I'm going to go ahead and cover this up like this. And then I'm going to take this roller gauze and I'm going to roll it around. Again, when you're using roller gauze, you only want to make a couple of passes, overlap it about 50% of the time, or 50% of the bandage, and you don't want to make it too tight. If you notice that I'm just rolling it right against Genesee's skin here, again, I'm not pulling and making this really tight because I can cut off the circulation to her hand. So I'm going to make a couple of turns or passes across this injury. Now, typically what we'll do is when we cover the bleeding here, we're going to overlap it 2 times and then go about 1 inch on both sides. And then once you've gone 2 passes, again, put your fingers in the center there, make a loop, and then I'm just going to go ahead and insert that in there, and that'll hold on to it. And in that way, if I have to put more gauze later on, let's say that she continues to bleed, I can add more gauze, pull this out, and continue wrapping it around. So I think that I've got bleeding controlled here. If it continues to bleed, as I mentioned, direct pressure and elevation are your first 2 ways of controlling bleeding. If this doesn't work, I'm going to come underneath her arm here, and I'm going to use what's called a pressure point. We actually have 4 pressure points on the body. In Genesee's arm here, underneath her bicep, she has what's called the brachial artery. And what I can do is I can come underneath her bicep and I can pinch in or press in with my fingers. And what I'm doing in this case is I'm pushing the brachial artery against her bone here called the humerus. And what that's doing is it's cutting off the major supply of blood to this limb. It's very important that you control bleeding as soon as possible. Adults typically have 12 to 14 pints of blood, and if they lose 2 to 4, it can be life-threatening. So someone can easily bleed to death in as little as a couple of minutes. So it's very important that you control this immediately. Now, if I do this direct pressure or this pressure point, I'm going to put pressure on there. If I control bleeding, that's it. I can't take my hand away. I'm going to have to maintain this pressure, because if I let go, blood, it's just going to start bleeding again. So once you put that pressure point on there, you're stuck there. If you have somebody else that can help you, another first responder, it's better to let them do that, and then you can move on with your head-to-toe assessment. I'm going to go ahead and put your hand down for a second. So as I mentioned, there are 4 pressure points. So there's one right here on the right arm. So this would be for any bleeds that I can't control on the right arm. On the left arm, it's going to be right here. And then in the legs, where sometimes people will cut what's called the femoral artery. This typically happens at warehouses where people are cutting open boxes with knives and stuff like that. And they'll cut the box open and they'll actually cut that femoral artery. We'll do the same thing. We'll put bandages on there and put pressure on there, but if we can't control it, the next 2 pressure points are right here in the groin area. And what we can do is put our thumb in the hip, run our finger over into this groin area, and I'll take the heel of my hand and I'll actually press in as hard as I can, and I'll actually push the major artery, the femoral artery, against this bone here, the iliac crest. If I can't control bleeding with just direct pressure and bandages, I'll use pressure point. Again, if I can use another rescue or another first responder, that would be great, because then I can go on with my head-to-toe assessment. So it looks like we've controlled bleeding with Genesee here. Now, we want to talk about fractures. In fractures, same thing applies. The mechanism of injury, point tenderness, and swelling may be an indication that there's a fracture. In worst case scenario, there's actually bone ends sticking out. You never want to press these bone ends down or back into the skin there. They're very painful. But what you do want to do is actually just wrap them up. Put some gauze over them and wrap them up, because anytime bone ends are protruding through, you've damaged the skin and you open up the body to infection. So you just put some gauze on there and a very light roller gauze over the injury. And then you want to immobilize that arm. Same way with legs. If somebody's injured their leg, you want to immobilize the 2 legs. Now in this case, Genesee fell, and if you've fallen 3 times your body height, or the mechanism of injury suggests that she may have a neck injury or an arm injury here, I want to immobilize the arm. Whether she dislocated her shoulder, she broke this bone, or these bones down here, I want to immobilize, because she says there's a lot of pain there, and I also note that there's a very large bruise there. So in immobilizing the arm, very good, I'm going to have her hold her arm up against her chest. And a lot of times when people have hurt their arm or they broke their arm, they want to hold it in tight against their person there. And that is a good idea, because that will help me immobilize that arm. Now, you can use splints, you can use SAM splints, you can use wood, you can use phone books, or anything you want to immobilize the arm. 2 simple ways of immobilizing the arm is using actually what's called triangular bandages. Triangular bandages are about under $1, and 2 of these can actually immobilize somebody's arm. When you open up a triangular bandage, it's going to have 2 long ends and 1 small end. And as we say in our business, the elbow is going to be in the side pocket. So when I want to immobilize Genesee's arm, what I'm going to do is I'm going to take this triangular bandage, the 2 big ends, I'm going to drape this underneath her arm there. The elbow's going to be in the side pocket. One end is going to be over here, and then the other end we're going to take and put it over on the other side here. And then I'm going to take the triangular bandage, and I'm going to tie it. Now I'm actually going to move her hair and get that out of the way so I don't tie that inside this triangular bandage. So I'm going to pull this out of the way. Now note that her arm is up kind of high right now for me attaching this triangular bandage. And I want to keep it up high, and I'll show you why in just a minute. And then what I'm going to do is I'm going to make the knot on the side of her neck here. If I tie the knot in the back, there's a bone in the back here, and if the knot is sitting on the back, it may be quite uncomfortable for her. So I want to make the tie right there. Now you can also tie this up as well, in that you can tie this in a knot, and that will make a little bit of a cup for the elbow. Once you tie this in a knot and this up, go ahead and let your arm go. You can see that her arm's going to come all the way down at about a 90-degree angle, and this is perfect. That's how you want that arm. And you always want the arm to be exposed here, the hand to be exposed. Once I've mobilized her arm for this possible break or fracture or dislocation, I can still see the injury in case it starts bleeding, and then I can pull this out really quick and start wrapping some more. And I can also do that capillary refill and check her hand for feeling. Now what I can do here to further immobilize her arm is I can take another triangular bandage and I can wrap this around her. I'm just going to go underneath your arm here. And then what I'm going to do is I'm going to wrap this around right along her arm. You can see her arm is here. I'm going to wrap this right along her arm. And then I'm going to tie this in the back. And by tying this in the back, you'll see that we've completely immobilized her arm. And now her arm is secured against her body. And then the last thing I want to do is come on over, and do you feel that? Do you feel me squeezing your finger? I want to make sure that she still has feeling in her hand, and I want to do that capillary refill. And that is, I'm pushing on her fingernail, and I'm seeing that I'm pushing the blood out and that it comes back. It'll turn white, and it should turn red again in about 2 seconds. So, we found Genesee. She was laying on the ground, or she fell off this ladder. We controlled bleeding. That was our priority. We've sent somebody to call 911. It's also very important. We've immobilized her arm because we thought it broke. Now, if you've called 911 and they're going to be responding in a pretty short amount of time, you may just have her immobilize her arm. But as a first responder, you definitely want to control bleeding. Another thing we can do with Genesee is treat her for shock. Anytime somebody's been injured or they've had some sort of infection or they're having a heart attack or something like this, they may be going into shock. And so in treating somebody for shock like Genesee, I'm going to make sure that there's no other injuries on the back here. And then all I'm going to do to treat her for shock is bring her down on the ground here. And some of the signs for shock is that they'll be a little bit pale on the face. They'll be breathing very fast, and the heart rate will be fast. So I can take note of how fast she's breathing. I can look at her skins and see if they're pale. I can see if she's sweating. I can see that she's breathing fast. I can even check that pulse. Again, I can check the pulse on the side of the thumb for 30 seconds, and then I can times that by 2. And if Genesee's going into shock, she's going to be breathing at a rate of probably faster than 12 times per minute, somewhere around 20 times per minute. She's going to be kind of pale looking. She's going to be sweaty. And she's also going to have a heart rate of probably faster than about 100 beats per minute. And so in treating her for shock, I've laid her down. And again, because of shock, blood pools into this area. I'll go ahead and raise the feet 12 to 16 inches. So I'm going to take my first aid bag here. I'm going to put the lid over, and I'm going to elevate her feet 12 to 16 inches. Now, I'm only going to elevate her feet if I'm sure that she hasn't broken her leg. In elevating the leg and treating people for shock, you want to make sure that there are no broken bones in the leg, in that if you felt that somebody fell off of a ladder and Genesee complained of pain or tenderness in the leg, she could have broken the big bone right here called the femur. And in this case, if she broke her femur and we elevated her legs, we might cause that bone to shift and actually break blood vessels inside her body. So one of the 2 times that you don't treat for shock, that is lay them down and elevate the legs, is if you think there are leg fractures. You may lay them down, but don't elevate the legs and keep them immobilized. And number 2 is when somebody's having respiratory emergencies. Do not lay them in the shock position because it's more comfortable for them to be in an upright position so that they can breathe. Once I put Genesee in the rescue or recovery position or the shock position, I can cover her up, or I can do what's called a head-to-toe assessment. And a head-to-toe assessment, I know that EMS is coming, I've controlled bleeding, I've immobilized her arm, I can start at the head and work my way all the way down. I can look in her ears for bleeding, on her nose. Now I do note on her nose that she's got a little blood coming out of there. And what happens in some cases is when some people fall and hit their head, they can have some clear fluid come out of the nose called cerebral spinal fluid. If you ever note that somebody's bleeding and there's clear fluid coming out of the ears or the nose, you want to make sure not to control that bleeding. That is, don't pinch it off because the brain can swell. Again, we can look at her eyes for swelling pupils or blown pupils, which is also an indication of possible head injury. We can go all the way down and see from head to toe. That is, again, check her bones, move her leg like this, make sure that everything is nice and stiff and that there's no pain. As I go down and palpate Genesee's legs and stuff, I want to ask her if that hurts when I do that. And then finally, what I can do to make sure she has feeling all the way down into her feet is I can ask her to go ahead and push down on my hand. Go ahead and push down. Perfect. Push down on that one. Excellent. And then pull back. Pull back on my hands. Perfect. And then do you feel me squeezing your toe? So these are indicators that she still has good nerve action. That is, her brain is working. She possibly doesn't have any spinal injuries because she's got feeling in her feet. She's got movement in her feet. She has movement in her hands as well. And we might do this every 5 to 10 to 15 minutes to ensure that she still has feeling in all of these extremities. And then the last thing I can do when I'm pretty sure there's no other injuries is I can take my blanket and I can finish the shock position and put a blanket over Genesee and wait for EMS. The only other thing that we didn't do here is what's called spinal immobilization. And in fact, if I thought, I'm going to go ahead and take your feet up here, so if I thought that Genesee fell off this ladder, and again, if it was 3 times her body height, if the mechanism of injury suggested that Genesee had a neck injury, I would definitely want to be immobilizing her head, in that I could talk to her and ask her to keep her head immobilized, but if I had to do this for her, I could take my hands and hold both sides of her head, and that would keep her head immobilized. It is very important that if somebody has been hit by a motor vehicle, they have fallen 3 times their body height, or maybe they've dove into a very shallow pool, that you treat them for this very, very serious injury, neck injury, in that if you don't hold on to their head and they move their head around, they could exacerbate or make their current injury worse. And sometimes these things happen over time. So just because she doesn't have any pain right now, if she fell from a very high ladder, not this one here, but a very high ladder, she may have an injury and not even realize it. And over time, it could get progressively worse. So spinal immobilization, calling 911, controlling bleeding are your priorities when somebody has fallen from a great distance. Some other first aid products here is what's called hot and cold packs. Now typically when somebody has sprains or strains, that is, they've twisted an ankle and they have some bruising, we can typically do 2 things with those. There's a recipe called RICE, which is rest, ice, compression, and elevation. So say that somebody sprained an ankle or a wrist or something like this. The first thing you need to do is rest, of course. Don't use your wrist. Try to stay off your foot. Of course, that area typically will swell. So by putting ice on there, you might reduce some of the swelling and make it heal a lot faster. The nice thing about the new chemical packs is that you can actually purchase these, in that there's just a chemical in here, a liquid, and you just pop that ampule, shake it around, and it's instantly cold. And these are great for first aid kits because you get an instant cold kit. You can, of course, also purchase certain kits where you can actually put them in the microwave and heat them up, or put them in the freezer and make them cold. Now the general rule is that if you're going to put a cold pack against somebody's skin, you never want to set it directly against the skin. Always have something between the skin and the cold pack, in that when we put ice cubes or something right against the skin, there can be a little bit of a freezer burn, if you will, right against that skin. So try to wrap it up in a towel and then put it against that injury. So rest, ice. If you have to wrap that ice pack around there and hold it on there for roughly 24 hours, not the full 24 hours, but you want to keep it as cold as possible the first 24 hours. That's what you want to do. And then afterwards, you can use heat. After 24 hours of sprayings and strains and stuff like that, you can start using hot packs, whether you use hot towels, hot water. Same thing applies to these hot packs in that you can just break the ampule, shake them up, and it gets hot for you immediately. Also a great idea for the kits there. Another thing I want to talk to you about is access to injuries. These are called shears, and we use these on the ambulance, and we use these to cut away clothes. Anytime you're providing first aid, if you need to gain access to an area that's bleeding, you want to remove that area as much as possible. In the cases of burns or where somebody has open injury, if there's anything in that wound or in that burn, if it's very loose and you can pull it out, you can do that. But we typically do not remove or pull pieces of cloth or fabric or sticks or debris out of injuries. So you kind of want to stay away from that. You can always rinse off injuries, but if they're very deep, like deep lacerations or cuts or anything like that, you don't want to rinse them off with water. Same thing applies. You just want to take some roller gauze and wrap that around there. You can put 4x4s on there, anything that's clean, and wrap it around. You want to prevent infection. Now, if something falls off of somebody, if somebody loses a finger, an ear, a piece of skin, or something like that, you always want to collect those parts. In the case of a missing finger or a toe or a hand, you want to, again, address the victim. Make sure that you wrap that area up. If they lost a finger, you want to make sure and wrap it up and prevent infection. You want to get the finger, the toe, the hand, whatever's there. And you want to wrap that on ice. A broken tooth, if a tooth has come out, again, you want to put that in cold water. You can put it in milk. You want to keep the missing part in something cold, whether it be an ice chest or in ice cubes or in cold water, like a tooth in cold water. A finger can be wrapped up with some ice, but again, don't put the finger directly on ice. Sometimes people have 2 or 3 hours before that limb can no longer be reattached. So time is critical in that you need to collect those limbs and gather them up and transport them with that person as soon as possible, whether you're calling 911 or not. And then, finally, after you've done using your gloves there, you want to remove these gloves. So this is my barrier device between bleeding and other body fluids. Once you're done with your gloves there, it's considered infectious waste. When you remove your gloves, you want to grab it by the collar or the sleeve here, and you want to pull your glove, inverting it or turning it inside out. As you pull that glove off, you wrap it up inside the hand there, take your fingers on the inside of the second glove, and you want to pull this off like this. That way, everything is inside that glove. Make sure that if you have a lot of blood or infectious materials at the scene, that you dispose of it properly in accordance with local and state guidelines.